Hello everyone, this is Dr. Shamama and today our topic of discussion is Fumarate hydratase deficient renal cell cancer this was my presentation during my rotation at Jain Unity Department of University of Washington. I want to say thanks to my mentor, Dr. Maria Tretyakova, who taught me the topic, gave me the slides, and gave me the opportunity to present there. So let's start. So what is FH deficient renal cell cancer? It's a very rare independent pathological subtype of renal cell cancer which was made an independent subtype by WHO in 2022. It is caused by either somatic or germline mutation of the FH gene located on 1q42.3 to 43. It's a highly invasive tumor. It's prone to early distant metastasis to either lymph nodes and bones. It lacks any effective systemic treatment. So overall, it's not a good disease. It's very aggressive. It has these mutations and it lacks any effective systemic treatment. So it's an aggressive tumor. Moving on, what's the background? A little bit on its background, it's important. In 2016, WHO classification of renal tumors, it labeled this tumor as hereditary leiomyomatosis and renal cell carcinoma syndrome associated renal cell cancer, that is HLRCC, associated RCC, which was caused by the germline mutation of the FH gene. But later it was found out that it's not just only the germline mutation which is causing this type of RCC, but it can also occur in somatic mutation of the FH gene can also result in the same type of RCC. That led to the development of this new entity separate from HLRCC associated RCC. And in 2022, WHO then developed it as a separate entity called FH deficient RCC, which is our topic of discussion today. A little bit on its epidemiology. It's a very rare tumor and the median age of initial diagnosis is 37 years, but the age range from like 13 to 75 years. So it's a broad range of age in which a patient can present. Male to female ratio, it's almost double in males as compared to female. That is 1.9 to 1 ratio. FH mutation carriers. Now people who have the mutation and they are carriers for that mutation, they have 15% lifetime risk to develop RCC. However, those who have a germline mutation and are part of the HLRCC syndrome, in that case, the lifetime risk is doubled. It's almost increased from 15% to 21%, and this is how its epidemiology is. Moving on, its pathophysiology. Now, how this has occurred due to the mutation. So that is what we're gonna discuss and understand today. So because of the FH gene mutation, that lead to loss of the FH enzyme activity. As a result, FH enzyme fumarate hydratase, which convert fumarate to malate, will not occur now. As a result, fumarate will accumulate within the cells. And this fumarate at high concentrations act as an oncometabolite, and it impairs the various cellular signaling pathways, and as a result a number of steps occurs like increase hypoxia inducible factor 1a activity, which lead to increased GLUT1 expression, increase NRF2 activity, which leads to promotion of the expression of AKR1B10, which is also an important stain for its diagnosis. This pathogenesis lead to that stain basis. Thirdly, it attenuates the cellular iron homeostasis, and fourthly, it drives the succinylation, which leads to the production of 2SC, which is also one of the IHC marker for detection of these FH deficient tumors. Now here, it's very important to understand that the pathophysiology which occur due to the mutation of the genes, that even help us to generate some metabolites which ultimately contribute to the IHC markers of that tumor. And this is what happened here. AKR1B10 and 2SC, 2-succinylcysteine. Now moving on, what is the diagnostic criteria which was given by WHO in 2022 to diagnose this entity? So one is the essential diagnostic criteria and other is the desirable diagnostic criteria. Now essential is which is of course required to make the definite diagnosis. It's either a demonstration of germline or somatic mutation of FH 1 point, or it's an IHC evidence of FH deficiency, that is FH loss or 2SC overexpression. So what's the essential criteria? Either it's a mutation in the FH gene or it's the IHC expression of the FH loss. These two, either of these, if it's present, is sufficient to make the diagnosis. This is the essential criteria. Now moving on, to the desirable criteria, that is presence of the histological patterns in multiple and mixed architectural patterns, we'll discuss later on, with at least focal macronucleoli. It's a pathognomic feature of the entity. And second desirable criteria is clinical or family history of HLRCC associated syndrome, either like skin or uterine leiomyomas. Now, let's start with the actual pathology of it, which would be interesting. We being pathologists, that was just to understand the entity. So, main part starts here. Gross description. How we will see this tumor when we would do the grossing as pathologists. So, tumor, it mainly involves the renal parenchyma, but few can also involve the renal medulla. And it's a solitary, means single. It's unilateral mass, can be solid or cystic. Now the solid area would be the grayish white, grayish brown, solid, medium in texture, while the cystic area, it would be a smooth wall with clear fluid in it. And the maximum diameter of the tumor is again a long range from 3 centimeter to 16.9, approx 17 centimeter. Now this is an example of the gross description, how it would look like. That, see, here you can see that this is the grossly tumor. This arrowhead, it shows that this is the infiltrative margin of the tumor. This white arrow, it shows that it involves the renal vein. And here the tumor has involved the renal pelvis. This is its invasion in the renal pelvis, and shown by the black arrow. This is how it would look grossly. Moving on to its microscopic description. Now, microscopically, it is a high-grade tumor and it has various patterns. Okay, so the patterns can be papillary, tubular, solid, cribriform or sieve-like pattern, cystic, collecting duct carcinoma-like or sarcoma-like pattern. So it has various patterns and it's a high-grade tumor. Now I would discuss the individual patterns. Now this is a good example given by my mentor, in which we see tubulopapillary growth with eosinophilic cells. Now I would like to highlight here is that, see, this is the whole tubular growth in which the cells are arranged in a tubular pattern, and this pale eosinophilic area in the center is basically the lumen of the tubule. And in some areas we do see some fibrovascular cores, and the branching architectural pattern, that is basically the papillary pattern. So in this tumor it is showing both patterns. That's why it's called tubulopapillary growth. And all over we can see these eosinophilic cells. I have zoomed up at higher power. See, this is the tumor eosinophilic cell with this pale eosinophilic cytoplasm, large nucleus, prominent nucleolus in the center, and this clearing around it is the perinucleolar clearing. I'll explain these features more in detail now, but this is what I'm explaining in this picture. I hope it's clear. Second, I mentioned it can present in either cystic or solid pattern. Now this is the cystic pattern. This is the whole solid pattern. And papillary pattern, see, these are the papillary structures which are basically cut in this section. So we are seeing these papillaries. These are like the cross section of those papilla. So this is the papillary growth pattern. This is the cribriform pattern. Now cribriform is like a sieve. Imagine it's a circle with multiple holes in it. So that's a sieve-like pattern. We do see sieve like these lumens. So it's giving a cribriform or sieve-like pattern. This is the adenoid pattern, the second picture. Adenoid pattern is in which we see a glandular formation. So here we do see like these glands are formed. These glands are formed with lumen in between. So this is adenosis or adenoid pattern. Then solid pattern. Now what do you mean by solid pattern? Solid pattern is like the tumor cells, they are present in a sheet of cells, like no lumens are present, cells are back to back, tightly packed with each other as a solid growth. So this is how we see here. Now mixed solid and papillary, clear, I've already told you what a solid growth is, clearly seen here, and I've shown you already what a papillary growth is, in which papillary structures are present with lumens, cut cross section. So this is the papillary growth and solid mixed within the same tumor. Now, moving on, that tumor cells, they show heterogeneous morphology. As I mentioned before, I'll explain you again. It's in high grade morphology. Cell will have abundant, clear, partially clear, or moderate eosinophilic cytoplasm with large nucleus in the center, and then eosinophilic nucleolus, which appear as an inclusion like, and the perinucleolar means surrounding the nucleus, it's clearing, it's halo, and this is the characteristic pathognomic features of the entirety, and it's also called CMV like nucleoli. Now, mostly it's this high grade morphology, but in some cases we do have eosinophilic low grade morphology, and of course it's low grade, so it would be associated with a better prognosis. Some cases we can have hyalinized or edematous fibrovascular cores with micropapillary fronts just coming out of that structure, and no foamy histiocytes are seen. Now this is what I was showing you, very clear picture of that these are all the tumor cells. They have this eosinophilic, moderate eosinophilic, partially clear cytoplasm with this large nuclei. This central dot is the inclusion like nucleoli, and this white area surrounding the nucleoli is basically the perinucleolar clearing, and this picture depicts all of the characteristic features. Moving on, this is again a good example of nucleoli with this perinucleolar halos or clearing. Now, I told you before that it can also present as an eosinophilic low-grade morphology, and this is by what I meant that the tumor cells are not that aggressive, they are low-grade in these tubular pattern, probably these. Now, how we can diagnose it IHC? I told you the histological features. Now, by immunohistochemical patterns, the most important stains which are negative here are FH, which is the fumarate hydratase stain. Of course, by name suggests FH deficient RCC means FH would be loss, negative. And second is carbonic anhydrase 9, that is also negative in it. It's also a characteristic stain for its diagnosis. And this is a good example of FH IHC. We do see that these are all the tumor cells which are clear, and they have no expression of the FH. While this brown area, you will be confused that, hey, I do see some brown area, but that's not the tumor cells. That is basically the retention of the stain in the non-neoplastic surrounding stroma. So this is basically the stroma staining, and we can also call it the background staining needs to be ignored. So moving on, the second important stain is the carbonic anhydrase 9 stain, and see these tumor cells and we don't see any staining, no brown color here, so it's negative in this tumor. Now, which stains are positive? PAX8, which has a nuclear staining pattern, is positive in it. 2SC, I already mentioned before by its pathogenesis that 2-succinylcysteine, there is a mechanism by which 2SC is elevated, and that's why it's overexpressed when IHC stain is performed, and it's both diffuse cytoplasmic and nuclear staining. Okay, and the third important stain, which is also from its pathophysiology, that is AKR1B10 expression. That's an aldo-ketoreductase, and it's also diffuse cytoplasmic and nuclear staining. Now I'll show you the images. This is the PAX8 example, and these are all the tumor cells which show diffuse nuclear positivity, these all areas, and that's in FH deficient RCC. Moving on, 2SC. 2SC is both cytoplasmic and nuclear, and it's evident here. This image is not that clear. I took it from a research paper, but if you can just zoom in and see that these tumor cells, they do have a nuclei positive, these dots you see, and the granular cytoplasmic staining too in the surroundings. So that means it's most positive there. This is 2SC, and it's more sensitive and specific as compared to the FH gene loss mutation, then leading to loss of FH on IHC. So as compared to the loss of FH on IHC, the 2SC overexpression is more sensitive and more specific for diagnosis. And third stain is AKR1B10. It's both, I mentioned, strongly positive cytoplasm and nucleus. We do see here these dots, they indicate nuclear positivity, and this pattern surrounding the cells, that smudgy pattern around it, I would say that's the cytoplasmic staining, and it has high sensitivity and specificity for diagnosis of FHRCC. It can be used as a potential marker for its diagnosis. Now moving on, there are a couple of other stains too which are positive, but those three which I mentioned before, positive and two negative, they are most important and main stains for diagnosis. Other things which can be positive here are either vimentin, that is a cytoplasmic staining pattern, GLUT1, membrane staining pattern, P53, S100A1, both cytoplasmic or nuclear expression, SDH-B and INI1, that's a nuclear stain. Negative are MRCR, RCC, TFE3, which is the transcription factor E3, CD117, CK7, CK20, and high molecular weight cytokeratins. Now, moving on to the cytology description. Now, how it would look cytologically, that it would be markedly enlarged malignant cells. Those cells, they would have abundant voluminous cytoplasm. It would present in three-dimensional focal clusters or papillae in a background of mixed inflammatory infiltrate. Don't worry, I'll show you the images. And the cytoplasm is mostly finely vacuolated. By vacuolated, I mean that it will be like small clear vacuoles. You see with like clear spaces in the cytoplasm with peripheral clearing on the margins, and variable sized vacuoles. It can be there. Pap stain preparations show intranuclear cytoplasmic pseudo inclusions. Now, what do you mean by this is that if this is the nucleus, okay, if this is the nucleus, right? So within the nucleus, you see cytoplasmic pseudo inclusions, like cytoplasm are, it would appear as cytoplasm are pseudo included there as an inclusions there. So this is how it would appear. On search path, they are enlarged pleomorphic nuclei with prominent inclusion like macronucleoli. Now these are all the description I was telling you before. These are the three-dimensional clusters with increased cellularity. This is again cluster which is forming these abortive papillae, and they have these associated fibrovascular cores. Now, the touch prep preparation, it shows these large papillary structures with metachromatic stroma, and papillae have these, hyalinized are these pink proteinaceous material. So this is the, I guess, I'm not sure. This is the hyalinized cores, a feature which is strongly suggestive of FH deficient RCC. Here we do see the characteristic cells with this large cells, eosinophilic cytoplasm, nuclei are enlarged. In some cells, nuclei are eccentric, pushed to the periphery, with these dots, big dots within the nuclei are the prominent nucleoli. And here you do see some bubbly appearance of the cytoplasm, and that is the vacuolation within the cytoplasm of the tumor cells. Moving on, the differential diagnosis. Now we have discussed the whole entirety. Now, what are the other diagnoses which appear the same of it, and how we can differentiate those renal cell cancers to our entirety? Characteristic nucleolar features are important, cytoplasmic and nuclear reactivity of 2SC, and loss of FH expression. Now, these three are the major features on the basis of what we differentiate our entirety from the differential diagnosis. Now, what's the first differential? The first is papillary type 2 RCC. It's often this type of tumor, it expresses MRCR and CK7, while these both are negative in FH deficient RCC. So can be differentiated. Further on, 22% of the cases, they do show cytoplasmic reactivity of 2SC, but nuclear staining is less likely to be diffuse as compared to the diffuse staining we see in FH deficient RCC. And other steps which are used for differentiation are CD10 and P504s. The second differential diagnosis is the clear cell renal cell cancer. Now, how it can be differentiated? Because clear cell has loss of chromosome 3p, while our entirety has loss of FH gene on chromosome 1q. So one difference. Second, it shows membranous carbonic anhydrase staining and no SC2SC reactivity. But in our case, in FH deficient RCC, carbonic anhydrase 9 is negative and 2SC is overexpressed. so entirely opposite to this entity. Collecting duct carcinoma, it has CD10 and 2SC negative, while in FH deficient RCC, 2SC is positive. Now, MIT family translocation associated RCC, which is Microphthalmia transcription factor, that shows TFE3, which is transcription factor E3 stain positive and 2SC negative, entirely opposite to what we do have in our FH deficient RCC, which is TFE3 would be negative and 2SC would be overexpressed. The fifth, I believe, is unclassified renal cell cancer, and that shows 2SC negative, while in FH deficient RCC, 2SC is overexpressed. Now, low-grade eosinophilic renal tumor, that needs to be differentiated from low-grade FHRCC. And how we'll differentiate it? That in this low-grade eosinophilic renal tumor, there is low-grade eosinophilic renal tumor morphology with GATA3 positive, CK7 diffuse positive, CD117 negative, and FH is retained, 2SC is negative. Now here the difference would be that CK7 is negative in FHRCC, FH is lost, which is retained here, and 2SC is overexpressed, which is negative here. So this is, we'll differentiate the both entities. And the last is SDH, which is succinate dehydrogenase deficient renal cell cancer. Of course, by its name, it would have the germline mutation of the SDH gene, and SDH protein expression lost would be seen on its stain. So this is all about FH deficient RCC. Now there are two practice questions in the end that I'm going to discuss now for you to understand and judge your knowledge, how much you have gained from the video. So the first question is, it's a 36-year-old patient who present with a renal mass. Histology shows large eosinophilic tumor cells with irregular nuclear contours, prominent eosinophilic nucleoli surrounded by perinucleolar halos, and frequent abnormal metastasis. Which of the following findings is most suggestive of FH deficient RCC? Either A, it's diffuse membranous CAIX expression, loss of chromosome 3p, B, retained FH expression, diffuse CK7, GATA3 positivity, absence of 2SC reactivity, C, loss of FH, CAIX, CK7, overexpression of 2SC, AKRB10, D, rearrangement of TFE3 or TFEB genes with nuclear TFE3 positivity, infiltrative, or E, which is infiltrative medullary growth pattern with CD10 and 2SC negativity. Now, in this question, I would like you to first identify which is the finding suggestive of FH deficient RCC, and in addition to that, also try to identify that by the differential diagnosis, which I've told you before, which matches the rest of the options, and try writing them on paper after reading it, and then move on to the next slide. I would say just pause the video here, evaluate what you have understood so far. So I guess you guys are done with your answers, so let's move on to the answer. So the correct answer is C, which is loss of FH by its name, CAIX and CK7 lost, with overexpression of 2SC and AKRB10. They are mostly seen in FH deficient RCCs. Okay, now I hope everyone is correct, and I would like you guys, whoever see the video, just share your answers in the comment section so that I know that you know how much you are engaging and understanding from the topic. Okay, and the remaining options, A was incorrect because diffuse membranous carbonic anhydrase expression and 3p loss is clear cell renal cell cancer. The B option, which was FH retained, CK7 and GATA3 positive, was low-grade eosinophilic renal tumor we discussed before, which needs to be differentiated from low-grade morphology pattern of FH deficient RCC. D was incorrect because TFE3 and TFEB rearrangements were associated with MIT family translocation RCC, and that lacks the nucleolar halo feature too. E was incorrect because infiltrative medullary growth with CD10 and 2SC expression negativity is typical for collecting duct carcinoma. That's for that. I hope you guys found it correct, and even if you don't, you can just always go back, understand the topic again. Let me know in the comment section if you need me to elaborate any of the point. I can make a separate video on that. So good one. Let's move on to the second question. So the second question is a renal mass with 35-year-old patient from that, and the histology is in the image. So just take a minute, see the histology clearly, and what I would like to suggest you and like you guys to do is just take a paper and actually write the morphology of this image, what you are seeing, and then make the diagnosis. Now, it can be the entirety, it can be the differential diagnosis. So don't just be biased that, of course, it's the topic, so the question would also be made on topic. It can be the differential too. So just focus. Now, 1, 2, 3. I hope you guys are done with the answer and you have paused the video. Now let's move on to the answer. Oh, I'm sorry. I'll tell you the options first. My apologies. So first is clear cell renal cell cancer. That's nest of cells with clear cytoplasm and delicate branching vasculature. Papillary type 2 RCC, which is papillary architecture with pseudostratified eosinophilic cells and foamy macrophages. Third is FH deficient RCC, which is cells with pale eosinophilic cytoplasm, inclusion like eosinophilic nucleoli and perinucleolar halo. D is collecting duct carcinoma that has infiltrative nest of high-grade cells in a desmoplastic stroma at the medulla. And E is MIT family translocation renal cell cancer that has papillary nested growth with clear eosinophilic cells and Shamama bodies. Now you should take your time and write the answers, and let's move on to the answer. You can pause the video here and think your answer and write in the comment section what you have decided. The answer is C, FH deficient RCC, because it has this eosinophilic cytoplasm, inclusion like nucleoli, perinuclear halos, which are the diagnostic clues for FH deficient RCC. A was incorrect because it shows clear cytoplasm with delicate capillary network and not nucleolar halos. B was incorrect because in papillary type 2 RCC, papillary growth with pseudostratified eosinophilic cells lacking inclusion like nucleoli and halos. D is incorrect because collecting duct carcinoma arise within the medulla, and that shows infiltrative cords in desmoplastic stroma, not the nucleolar halos. And E is incorrect because in MIT family translocation RCC, that shows papillary nested growth with Shamama bodies but lacks the perinuclear halo feature. So I hope you liked the video. And if you did, just share your feedback in the comment section, share your answers too in the comment section, and let me know if you have any questions. You can pop it up in the comments, and thank you so much. See you guys in the next video.